dealing with old people. When you have an old person with an S3, it's in heart failure, period. One of the few questions that you can have in English that is what you call that sound questions that you need to take the the this device and hear the question is that you can hear an S3. Remember that normally the heart has two sounds, S1 and S2. Dot dot. Yeah. The S1 is the beginning of the systole when the mitral valve closes. Those sounds are produced when the valve closes. When the valve closes, this is the sound. When the valve opens, normally they don't produce sounds when the valve closes. So the S1 dot is the moment in which the heart, the left ventricle, the ventricles start contracting
Sí.
and are going to increase the pressure of the blood inside the ventricles, and this is going to close the door of the mitral. And when the mitral closes, preventing the blood from returning wrongly back to the atrium, that's why the mitral has closed, is closure of the S1. And the ventricle continues contracting, splitting, ejecting, moving forward the blood. There is a moment in which the ventricle cannot move more blood forward and decides to relax. And now the ventricle, relaxes and relaxes. This relaxation is called diastole. The diastole occurs when the ventricle is going to relax and is going to decrease violently the pressure inside the ventricle. For that reason, now the pressure in the aorta is going to be bigger than the ventricle, and the other valve that will close is the aortic. So the S2 is produced by the closure of the aortic valve. S1, closure of mitral at the beginning of the systole. S2, closure of the aorta at the beginning of the diastole. Between S1 and S2, systole. After S2, diastole, until the next S1. This is the normal. Sometimes an extra sound appears almost immediately after S2. And when it appears, it is the beginning of the diastole. Is when the heart is enlarged. There is cardiomegaly. And the walls are big and thin and are like a gelatin. So when they relax to suck the blood, to fill with blood, they vibrate, abnormally vibrate. And this extra vibration produced only when the heart is enlarged produces this abnormal sound called S3. So normally when you are hearing the heart, you're going to be hearing so 1, 2, 1, 2, 1, 2. Now you are going to hear 3. 1, 2, 3. The normal is 1, 2. The abnormal is 1, 2, 3. And because usually you have tachycardia, because activation of the sympathetic nervous system in heart failure, this is going to be very fast. 1, 2, 3, very fast, no? And it sounds like a horse running, galloping. And that's why it's called S3 gallop. Summarizing, for anxious, S3 gallop is heart failure. Sometimes there is another abnormal sound. ¿Qué pasó aquí? Just a moment. This card, sorry. Wait, why is this not going on? Just a moment, I'm having a technical issue. I pushed something that I don't know what it is. Escape. What's an escape? Okay, how do I close this? No idea. Okay, no, I could close this. Sorry for that. So There is another sound that can appear that is called S4. S4. This S4 has not the meaning of S3. It's less severe. It's not normal. It's not normal, but it's less severe. The S4 means basically the most common cause that the heart is old and is stiff. When you grow older, the cardiovascular system becomes stiffer, less elastic, less compliant than in young people. The arteries become very stiff, and for that reason, systolic hypertension is so common in older people. And the heart also becomes stiff. And because this loss of elasticity or compliance of the left ventricle, in the moment that the left atrium has the systole that occurs immediately before the ventricular systole, then there is going to be an abnormal vibration of the left ventricle, and you have this S4. So being old is not the best, but it's not so bad as having S3, which is heart failure at any age. Is clear? How is tested that in English? Try, and I don't have the question here because I didn't have time to collect the questions. But the question says the nurse is assessing as in a routine appointment a client, an old client. The old client need to walk a long hall until reaching the examination, room where the nurse is going to auscultate the heart of the client. So the client is walking, is doing an exercise until it reaches the room and lay down in the examination table to be examined. And the nurse auscultates an S4. And the question then is what the nurse is going to do. So give you the option to do an EKG, call the doctor, administer nitroglycerin, or allow the patient to rest for a while in assessing. The right answer, as you after the explanation understand, is the last one. There is expected finding in a person that is old and exercising. It's just wrinkles, gray hair, etc., that are not the ideal, are expected in the process of age. Okay, so now is you're able to differentiate the meaning of S3, very serious, need to be reported, versus S4, which is need to be documented and taken with a grain of salt because generally, of course, doctors give more interpretation to S4 because it could be a manifestation of a no well-controlled hypertension or a diastolic dysfunction of the left heart, etc. Because it's too medical and we need to keep nursing level. We need to keep anchorage level. Okay, so this is what you need to know about S3 and S4. In relation with heart failure, there is a test that you need to know if you don't know. It's called BMP. It is a substance. It's a protein, by the way. It's a peptide that is produced when the heart is enlarged, is stretched. Your heart is not enlarged, your heart is not stretched. But when there is somebody with heart failure, the heart becomes enlarged. And because there is pooling of blood inside, the heart is stretched. This physical phenomenon makes the heart react, producing a protein called BMP, natriuretic peptide. Okay, the B initially was related with brain, but forget it is not relation. It could be also called atrial natriuretic peptide. This is not important for the NP. What you need to know that a normal person with normal heart should have the BMP in low level. If this person or the other person develops enlargement of the heart, this BMP elevates. So elevation of the BMP means heart failure. Usually this elevation is in the range of the thousands. Okay, the normal value is 0 to 30. You don't need to memorize that. But when there is an important elevation, more than 100, suggests that the client is in heart failure. Having an elevation, having a level below 100 is rule out, discard the possibility of heart failure. This is the interpretation of this test. Have been tested? Yes. What about central venous pressure? What is the meaning of central venous? Are veins that are in the center of the body. Which veins are those? The vena cava. The superior and inferior vena cava are in the mediastinum, which is a structure, and the mediastinum and the adductor, which are structures that are in the center of the body. That's why are called central veins. To differentiate that from peripheral veins that are here in the extremities. Yes. And so when we say central venous, we are talking mainly about the vena cava. And which vena cava is more accessible to the doctor with a central catheter superior, the superior vena cava. Okay, entonces, generally when they talk about central venous pressure, they are talking about the pressure of the blood inside the superior vena cava that can be measured with a simple basic catheter as a routine doctors introduce in the superior vena cava. You know, this is the central venous pressure. The central venous pressure is very easily measured only with a ruler. The same ruler that have your child going to the school divided in centimeters. With this ruler, you can measure central venous pressure. You simply place the patient in flat position. The doctors introduce the central catheter. You connect the central catheter, of course, to a normal setting. But then also with connection T, you place here a ruler with a tubing attached to the ruler, connected with the normal setting and connected with and the zero of this ruler, the ruler has 0, 1, 2, 3, 4, need to be in the mid-axillary line. So the armpits, the axilla as the anterior line, the posterior line, and the midline. So need a 0 of the ruler need to be at this level. And then you are going to feel, here is this blue. You are going to feel this, you are going to feel that with normal setting, and then you clamp here the normal setting, you feel the tubing normal setting, and you wait for this normal setting to drop, to descend until stopping. When the normal setting stops and doesn't descend anymore, start descending, and stop anymore, no logro ver el, okay, here it starts descending, okay, descending, and stop. You measure how many centimeters stop the column of liquid, and you say this is the central venous pressure, the moment in which the pressure of this column of liquid equalizes the pressure that is in the superior vena cava, and it's called central venous pressure. The central venous pressure is very variable. It's not the best measurement, but for all us nurses, it's okay. A value that is accepted is 5 to 10, and it's a range that is easy to remember. It's a Katchen number, or Katchen numbers, and 5 to 10. But this is not the question in the Nclex. The question in the Nclex is, the client is receiving normal saline at 120 milliliters per hour, which is a relatively high volume of liquid. Doctors orders you to measure the central venous pressure every 2 hours. The last time that you measure the central venous pressure, the value is 80 centimeters of water. And the question is, what you do? And of course, you need to go to the options, okay? And the right option is to interpret that this pressure is increasing. Okay, so you don't need exactly to memorize the 5 to 10, but 18 is far beyond, far above the expected. And what is your interpretation? This patient has too much liquid, or this patient is not moving the liquid properly because the pump is failing. So the preload is too high, and it's not good. And you are infusing, forcing in the vein of the client liquid through at 120 milliliters per hour. And then what you do, the right answer is just stop the infusion and call the doctor. So try to imagine all the stuff. And what you expect the doctor will order? The doctor will order to discontinue the IV fluids and maybe administer furosemide. And what else you can do for the client, etc. This kind of stuff. But the answer to this question was you withhold the infusion and call the doctor. So this is the interpretation of that. This is the way that can be interpreted. Nevertheless, doctors use a more sophisticated method of evaluation of the preload. And they use a much, much longer catheter that is not stopping here in the superior vena cava. Is continuing inside the right atrium, the right ventricle, inside the pulmonary artery, and even is going to continue in one branch of the pulmonary artery until finding a narrow branch of the pulmonary artery. There, this catheter, which is connected to a computer, computers and transducers are devices, technical devices that can measure pressure in much more advanced way, not so primitive like with a ruler, you know. And for that reason, those pressures are measuring millimeters of mercury because are measured with a computer and a transducer. So now it is ordered to inflate a balloon. I don't know if you see the balloon here. A balloon is inflated, and when the balloon is inflated, is making a wedge in the walls of the pulmonary artery to cancel the action. Let me change the color. To cancel the pressure or the action of the blood that is coming in this direction. So now the tip, this is the tip of the catheter, is measuring the pressure here, the pressure of the blood before going to the left heart. So it's measuring the central venous pressure of the left heart. You understand? So it is much, much better. It's much, much better. And it's called pulmonary capillary wedge, because when you inflate the balloon, make a wedge pressure. Pulmonary capillary wedge pressure. Yeah. They can also measure the pressure in the pulmonary artery. They can measure the pressure in the right ventricle. They can measure the pressure in the right atrium, and can also measure the central venous pressure. But when they introduce these long catheters, okay, is with this purpose. Okay. It is basic. The interpretation is the same. The normal value is 6 to 12 millimeters of mercury. So if it is elevated, it's too much preload. It is decreased, a patient needs liquid. This is the interpretation. Going beyond, as Hesse does, that in which moment you measure the wedge pressure, if at the end of inspiration or at the end of expiration, etc., etc., it is too much. It is too specialized. I never seen that going so deep in Nclex, because Nclex test plan says this is an entry-level generalist nursing, and a specialties is not the purpose of this exam, and this is falling in the range of a specialty. So I just wanted to mention that, just in case you have some interpretation. So in 2 words, the primitive central venous pressure measured with a ruler has the same interpretation as the pulmonary capillary wedge pressure with Schwann-Ganz measured by the doctor with a computer and a transducer. If it is high, too much liquid, too much preload. It is low, too little liquid, too low preload, and the patient needs liquid. The interpretation is the same. The difference that this one is much more exact, is less affected by other variables than the central venous pressure. No problem with that. Understood very well. What else? You need to know. The central venous pressure, basically, the one that is in Nclex, is measured in centimeters of water, but could also be measured with this device, and in this case, it's measured with millimeters of mercury. In this case, in millimeters of mercury, it's between 2 to 6. But I don't see worthy to memorize those values, only to have an idea. So when they say 18, 20, you have an idea that it is elevated. Of course, what you expect in those clients, you elevate the head of the bed, You have a diet low in sodium, high in potassium. You may add decline to weigh daily, okay, or at least every 2 days. And you expect diuretics, loop diuretics, ACE inhibitors as a vasodilator, dioxin, that you know they increase the contractility of the heart, and it is very important. Low dose of beta blockers. The reason of giving low doses of beta blockers is to block the exaggerated activation of the sympathetic nervous system. And this is the role of the low doses of the beta blocker. This is going to decrease the mortality in clients with heart failure. So let's see a way of testing that. It is a client with heart failure and sodium restrictions. Which food could be recommended zero that apply? And you need to demonstrate your knowledge of the content of sodium of the food. So obviously, everybody knows that fresh fruits are low in sodium and are recommended. So I recommend this. What happens with the processed food? What happens with frozen vegetables? Vegetables are good, yes, but are frozen. And to be kept with the adequate color, to be yummy, to be preserved, they are added sodium, and they are processed with monosodium glutamate, okay? And the content of these frozen foods, the content of sodium of those frozen foods is elevated. So take care. If the vegetable is, como se llama, is fresh, is low in sodium. But if this process comes in a can or is frozen and packaged, has sodium. Homemade pickles. To make pickles, apart of vinegar, you need to use a lot of sodium. Of course, it is very high in sodium. Pickles one of the highest sodium content stuff. Even if what predominates in the taste is the acidity, the sour taste. Okay, they're high content of sodium. The soups in general, any soup, homemade or canned soups, are high in sodium. I don't know if you know how to cook, but if you are, making a soup, you need to add a lot of salt because it has a lot of water. And to make the soup tasty, a little taste, you need to add sodium. So soups in general has high content of sodium. Cheese is a processed food. Any processed food, a food that you don't do from scratch, is high in sodium. The trap here is a low fat. Okay, it's low fat, so it's low in fat, but not low in sodium. Cheese is high in sodium. Ham, cheese, cold cuts, all the stuff that you buy in the deli or the supermarket is very high in sodium. But a tossed salad, which is our fresh vegetable, with oil and vinegar, so a vinaigrette made by you without adding salt, is a good option. And this is the way that you answer this question. Another way of testing this concept, signs and symptoms of right heart failure, so that apply. Okay, so crackles, no, crackles is left heart. You remember? Crackles is left heart, is lung. Yeah, so no, crackles, no. Dependent edema, yes. We say dependent edema is hepatomegaly, congestive hepatomegaly, yes. Neck vein distension, yes. Nocturia, what we said about nocturia, yes. Why? Because the edema is reabsorbed at night and ends in the kidney producing nocturia. So it is a way of testing that. They can make another question with left heart failure with cellular apply. In cardiovascular, they can touch the topic of the congenital heart malformation, but they touch that very superficially. Don't waste time analyzing the deep pathophysiology of the abnormal communications in different congenital heart malformation. It is an entry-level generalist test, and this is a field that corresponds to the nurse specialized in cardiovascular diseases and the physician. What you need to know is that the heart can have factory defects and that the embryonic development of the heart is very complex. And when something has complexity, defects are frequent. So you can have defects in the heart. You can have abnormal holes. The most important, the most common, not important, the most common holes are in the wall that separates the atrium and the ventricle. Those are called ventricular and atrial septums. So atrial septal defect and ventricular septal defects are the most common. But there are many other malformations. In this kind of malformation, you have abnormal communication between the left heart and the right heart, and the pressure of the blood in the left heart is higher than the pressure in the left heart, and for that reason, you have an abnormal movement of the blood from the left to the right. It is going to bring problems. It's going to bring heart failure. It's going to bring overload of blood in the lungs. Because understand what is happening here. If we go to the first thought, okay, what we have here, we have blood coming legally. It is legal immigration. Okay, legal immigration. Blood coming here to the right heart. But now I have an illegal immigration of blood coming wrongly from the left heart added to this blood that is coming here. So what I have now, double blood in this area, which brings problems. Makes sense, no? Okay, so this is what happened. But it's interesting that this shunt from left to heart does not produce cyanosis. There is no blue blood going to the left heart and pumped to the lips. So there is not cyanosis. But how is going the nurse to suspect that a child born with this malformation, not identified at the moment of birth, is having a problem in the heart? The nurse is going to suspect that because it's seeing a baby that is having problems to feed. The heart failure, the problems of the function of the heart manifest more evidently when a person is doing exercise, is doing an effort, because precisely when you make an effort, you require more oxygen and blood, so the heart needs to work more. And the babies, the newborns, exercise when they are sucking, when they are feeding. They need to suck and swallow, and this is an exercise for them. So in this moment is when the child is going to manifest the symptoms of heart failure. The other moment is when they are crying, but is more evident when they are feeding. So what is going to happen to a baby that starts exercising, sucking, and now start experiencing shortness of breath? The priority, Maslow, what comes first? Breathing or feeding? Breathing. So the child stops feeding to breathe better. And because children are all time sleeping, so they fall asleep. So what is the scenario? A baby that starts sucking and then interrupts too early before filling the stomach, interrupt the feeding too early, and maybe you notice some distressed breathing, maybe sweating, okay, because the stress, and falls asleep. But what happens now? This baby is going to awake, is going to wake up sooner than expected. Why? Because ate too little and now is hungry again. So who is going to complain, the baby or the mother? The mother. Because the mother is complaining that this baby doesn't allow her to live. Because every 15, 30 minutes, the baby is waking up with hunger and start feeding, but then interrupts too early the feeding, falls asleep, and is feeding every 20 minutes. So it is one manifestation. The other manifestation is that the baby is having a delay in the growth, a delay in gaining weight and growing because is having problem of feeding, problems to thrive, problems of oxygenation, etc. Those abnormal holes in the heart could become infected, and this infection inside the heart is called endocarditis. So, summarizing, how you recognize in a baby that is having problem of heart failure when they are feeding. Yes, so they interrupt the feeding, but they are always hungry, and they have growth retardation. Also, when they are crying, you can notice the shortness of breath. There is another congenital malformation that needs to be studied independently because Nclex make a lot of questions. It's the most common cyanotic congenital malformation of the heart. It's called Tetralogy of Fallot. Fallot was the guy who described the condition, and tetra means four because there are four malformations in the heart. You don't need to know. You don't need to know that. I never seen that tested. This is not nursing. But you need to know that due to the combination of these four malformations, there is a shunt of blood, blue blood, from the right to the left. So now there is blue blood passing to the left. Now this blue blood is pumped to the lips, and the lips are going to be purple, are going to have central cyanosis. So this is a child that has lower than normal amount of oxygen in his or her blood, and as a consequence is going to have chronic cyanosis and is having consequences of this cyanosis. Having less oxygen, having heart failure, having a damaged heart, if it is left to the natural evolution, you are going to see a child with growth retardation, failure to thrive, but also you are going to see a child that is cyanotic, and you see the lips and the fingers, the nails of these children, you see a bluish discoloration. And also you are going to notice that to compensate, the blood produces, the bone marrow produces more red blood cells. So the hemoglobin and the hematocrit of those clients are higher than normal. English question. How is the hematocrit in a patient that has cyanosis? It not only is seen in tetralogy of Fallot, it's seen in other conditions associated with lack of chronic, long-term, okay, lack of oxygen, like for example, cystic fibrosis, like for example, COPD, or the tetralogy of Fallot, that are conditions that produce chronically along years of life low level of oxygen in the blood. How is going to compensate the body? Producing more red blood cells, more hemoglobin, trying to transport a little more oxygen to compensate, to improve the oxygenation of the tissue. And the other manifestation that you see in all those conditions that produce chronic hypoxemia and cyanosis is the deformity observed in the tip of the fingers called clubbing. So this word, if you don't recognize the word, need to be learned by you. And this is clubbing. Is a dilation of the tip of the fingers that, if you pay attention, even with the bad quality of the picture, can be seen in the fingers of this girl with tetralogy of Fallot. And you see that the nails, instead of being flat, okay, are like convex. So this is called clubbing. So clubbing is found when there is chronic, you know what I mean, chronic, no, long-term cyanosis, chronic hypoxemia, hypooxygen in the blood, hypoxemia, and you can COPD, cystic fibrosis, pulmonary fibrosis, tetralogy of Fallot, all those conditions that produce chronic problem of oxygenation. It's important to know that those kids with these defects, when they are exercising, remember again, they have exacerbation of the symptoms, and they becomes even more cyanotic. This is called cyanotic spell. No, it's like a cyanotic attack. That is something like a worsening of the cyanosis on the heart failure, and it occurs when they are exercising. When they are exercising, when this girl is grown, she can run, she can walk, she could be playing, and then develop this exacerbation. But also could be a younger child when is feeding or is crying, because I already explained to you that the way that small children do exercise is when they are sucking, feeding, or crying. And they cry, you know, when they cry especially when the nurse is near, because the procedure nurse do usually are painful. And when it occurs, if the child is able to squat, so squat is adopt this position that you see here. So this, what is this position? Okay, is a squatting, no? So those are the legs, are flexion, and what you are doing here, you are pushing the legs against the abdomen, and then you are decreasing, reducing the return of blue blood to the right heart. So less blue blood is passing from the right to the left. So less blue blood is reaching the lips, and the cyanosis improve. So squatting is a way that the child feels better. So what you do if you have a child, this is an excellent question. What you do, you have a child with Tetralogy of Fallot and suddenly becomes very cyanotic and adopt the squatting position. Leave this position. Respect this position. The other question in Nclex, you have a newborn that is born with Tetralogy of Fallot, has cyanosis, etc. And it start crying or start feeding and develop the cyanotic spells. What do, you tell the child to squat? No, because this child is not gonna squat. This child is not walking. So now you, or you teach the mother, are placing the child in the equivalent of the squatting position. So you place the child upright, huh? Head up, upright, and you flex the knees against the chest. Okay, you flex the lower extremities, moving the knees against the chest. So it is called the knee chest position. So it's simply that the child, you are going to move the knees against the chest. So it is the equivalent of the squatting position. Make sense? And of course you can put also. There is another malformation called coarctation of the aorta that is less frequent, in which the aorta is not in the heart, it's in the aorta, has a narrowing and the descending part of the arc. The aorta leaves the left ventricle and makes an arc and then descends. No, in this arc, the arteries that go to the brain, which are the carotids, and the arteries that go to the upper extremity are the subclavian arteries, are spared of the malformation. So those arteries are before the malformation. So the parts of the body that are going to suffer the consequences of this malformation are the lower part of the heart, the inferior part of the heart. So now what is the finding of a child born with this condition? It's a child that has okay, it's a child that has a strong pulses in the upper extremities, strong pulses in the upper extremities, but weak, okay, pulses in the lower extremities. Up strong, lower weak. Why? Because there is an obstruction here. This malformation is an obstruction here. So the pressure here is okay. The amount of blood and the pressure here is okay. The amount of blood and the pressure here is decreased. What is the consequence of leaving this narrowing without correction, because it's surgically easily corrected? What is the consequence of leaving this narrowing here? That the left heart is going to have an overload of work. Okay, so the left heart, because this obstruction here, the obstruction is here, the left heart needs to pump against a very increased afterload, and the consequence with the time it is not corrected is that the left heart will distend, will enlarge, developing left heart failure. This is the consequence of having an uncorrected, unfixed uh, coarctation of the aorta, and is easily diagnosed just touching the pulses in the upper extremities and the pulses in the lower extremities. So how could we apply that? The nurse is caring for a toddler who has a medical diagnosis of coarctation of the aorta. So has been already diagnosed medically with coarctation of the aorta, which assessment finding by the nurse should the nurse report to the healthcare provider immediately. Pulse oximeter 94%, crackles at the end of inspiration, weak femoral pulses, blood pressure higher in upper extremities. What do you think is going to be the right answer of this question of prioritization?
B.
Everybody agrees?
B.
Yeah, B.
Absolutely. You are right. You are right. B is what need to be reported because the other findings are expected. So what we learn here from this question, in any situation, in any question, in any condition, what is expected in the condition is not reported as an emergency. Because it is expected. So if a person has, I don't know, a pneumonia and has fever, this fever always needs to be reported, but not immediately. It's not the emergency. Why? Because fever is expected in a client with pneumonia. What is not expected in a pneumonia is to have the client with an oxygen so low that the patient can die. So maybe if the patient has an O2 saturation of 70, 75, this needs to be reported immediately. Make sense? Here they have the same situation. A slightly low oxygenation is expected and is not critical. A weak femoral pulses, sorry, weak femoral pulses is expected. You don't report something that is expected in a condition that has been already diagnosed. Yes? Having the blood pressure higher in the upper extremities than in the lower extremities is also expected because we said the obstruction affects the lower extremities, not the upper extremities. Yeah. But what is not expected is that the left ventricle has been already damaged by the increased afterload, developing left heart failure, accumulation of liquids in the lungs as a consequence of left heart failure. This is the complication. This is the non-expected condition. That's why the answer of this, the correct answer is B. The other question, the mother of a 3-month-old infant states that her baby has not been gaining weight. You start suspecting that something wrong with this child. 3 months should be gaining weight. With further questioning, the nurse finds that the infant falls. The nurse finds that the infant, with further questions, the nurse finds that the infant falls asleep after nursing and wakes up after a short amount of time hungry again. So it is another detail that I said is classical in babies with heart failure. What other information would the nurse want to have? What do you think is going to be a good answer here?
D.
D.
Presence of dyspnea for a sequence.
Exactly. If the baby presents shortness of breath and sweating when is sucking. Absolutely. You need to know that bacterial endocarditis, how it's tested in select of that apply question. Bacterial endocarditis means that inside the heart there is an infection. The problem of the bacterial endocarditis is that infection produces a clot. It's a mass of fibrin infected, full of bacteria called vegetation, like a vegetable. And this mass of fibrin that is inside the heart, generally inside the left heart, because this endocarditis is more frequent in left heart, is going to pump, is going to release fragments, pieces of this mass, of this clot, with bacteria to the general circulation. So the client with bacterial endocarditis is going to have, it's okay, sorry, okay, is going to have a clot here, and the clot is going to be pumped to the general circulation, Okay, no, I don't know why I cannot hide that. Okay, to the general circulation. And as a consequence, you are going to have a person with an infection inside the heart. What do you expect to be seeing? What do you expect to be seen in a person? I can hide that. Okay, I can do that this way. Aha, I could hide that. You are going to see a person with fever, with a septic state in bad condition. The endocarditis generally does not happen in a normal heart. Usually, endocarditis happens in previously damaged heart. So usually the person has previously a damage in the valve, mitral or aortic valve, or has an abnormal communication, those holes that I mentioned, septal defects, etc., etc. So the patient has previously a murmur as a consequence of this valvular damage, etc., etc. And one day, the person has, bacteria circulating in the blood, and the bacteria, lodge there in the damaged valve and produces the infection. An exception of this scenario is the IV drug users. IV drug users inject in their veins daily, many times per day, a very dirty, a very, contaminated substance, with contaminated needles and contaminated substances that are not sterile. And this can produce infection, especially in the right side of the heart. This is the exception of this common situation. So we have a patient have a previous murmur that now presents fever, deterioration, and start presenting embolization all the body. So those pieces of the mass go to the brain, go to the eyes, go to their kidneys, go to the liver, go to any part of the body. Each time an embolus is sent and lodged in any organ, is going to produce seeding of bacteria in the embolization. So now you can have abscesses in the brain, abscesses in the meninges, you can have abscesses in the kidneys, in the liver, etc., because you are sending bacteria. With the clot, you are sending bacteria to those organs. But it's easy to see the embolization in the skin, because you are going to see, for example, in the extremities, the final end arteries of the extremity, you are going to see embolization, digital embolization. And you are going to see in the skin little dots, elevated nodules that are painful because are embolized in the skin. So you are going to see petechiae, you are going to see different sign of embolization in the skin. Of course, the heart is going to have a progressive deterioration of the valve, which is going to make the murmur more intense, and heart failure can appear as a new onset heart failure in those clients. Those clients frequently are diagnosed on times and with long periods of antibiotics, because blood culture, demonstrate a type of bacteria that more frequently produce that. Streptococcus and staphylococcus are frequently cause of that. Any bacteria could produce endocarditis, and sometimes the valves are so damaged that need to be replaced. So they could have a replacement of the mitral or the aortic valve. Talking about valve replacement, the question about valve replacement that I've seen in Nclex is that you have two types of valve replacement: mechanical valve replacement and biological. Bio is life, no? Biological valve replacement. The mechanical valve replacement means that they do the surgery, they open the heart, they remove the damaged valve, and they replace this damaged valve with an artificial valve made with plastic and metal. These mechanical valves are very good, last a long time of lifelong, but has a defect. They have tendency to produce clots, which is no good, having clots in the heart because can be pumped to any part of the body. For that reason, clients that had this mechanical valve replacement need to be lifelong in anticoagulants, generally warfarin. The biological valve, the most commonly used biological replacement is the valve of pigs. Okay, so porcine, okay, valve, okay, pig, okay, um, valve are used in biological replacement. They have the advantage that they don't produce clot and there is no need of anticoagulation. These valves are going to last less years than the mechanical, so frequently needs to be replaced, but has the advantage of not needing anticoagulation. Anticoagulation is a risk. To be anticoagulated is a risk. And that's why the tendency nowadays is to do more biological valve replacement than mechanical valve replacement. The question in the English is very simple. Do you know which one requires anticoagulant? And you're going to answer the mechanical valve. It's obvious that a plastic and metal can produce clots much more than a tissue that is biological of an animal.
Professor, I have a question.
Sure.
Just which one has a higher? Is there any difference in the risk of infection?
You mean in the replacement valve?
Yes. Is there a higher risk of infection on the biological or the
No,
mechanical
no,
or
no,
something
no.
like
It
that?
is not reported. It is not reported as an important difference. Okay.
Okay. Okay. Thank
The problem of the infection is when the valve is not replaced. Is when the valve is damaged by a previous disease. The valve in the past, the most common cause of damaging of the valve was a immunological phenomenon, because it's an immunological phenomenon called rheumatic fever. The rheumatic fever happens when a young person, I'm talking about a child, adolescent, or very young adults in their 20s, has an strep throat. This strep throat can trigger an immunological reaction. It's called a hypersensitivity reaction. Okay, is a type 2 hypersensitivity reaction in which undesired abnormal antibodies are produced as a consequence of the infection in the throat, antibodies that get confused and attack the valve of the heart. Not only the valve of the heart, attack the joints, attack the skin and the subcutaneous, can attack even the brain, yeah, but attacks all the heart, but especially the valve of the heart. So it's called rheumatic fever. Produces fever, that's why it's called rheumatic fever. So do you think that rheumatic fever has fever? Obviously that yes. You need to have a certain common sense, no? Yes, there is fever. And why is called rheumatic? Rheumatism sounds something like arthritis. Yes, there is arthritis in this condition. The attack of the brain can produce abnormal movement. It's called chorea. chorea of Sydenham. And the attack in the skin can produce erythema in the skin, can produce subcutaneous nodules. But all those symptoms that I just described will disappear spontaneously without treatment. But the heart gets very inflamed. Like there is a pancreatitis, a pericardium, a myocardium, endocardium, everything is inflamed. But after this inflammation subsides, what is left damage are the valve, especially the mitral and the aortic valve, and from both, especially the mitral, can be left deformed. Maybe they are not closing properly and they are incompetent. They are having regurgitation of blood. Or maybe they are in the healing, in the scarring, they are left too narrow, and it's called stenosis, mitral stenosis, etc. Those are the clients that had this condition in the past that more frequently have endocarditis. Those clients need to be very careful when they go to procedures that are invasive and can produce transient bacteremia, like having a deep work in the teeth when they go to the dentist, or when they have endoscopies, colonoscopy, biopsies, curettage, this surgery, etc. They receive prophylactic antibiotics before the procedure to have a level of antibiotics in the blood when this bacteremia occurs as a consequence of the procedure, and to prevent the endocarditis. It's not common to have, even if they could have, okay, the prosthetic valve could have prophylaxis, it's not so common, the condition in the valve replacement. Talking about pericarditis, I already mentioned that several conditions, many conditions can produce liquids spilled in the sac that surrounds the heart called pericardium. And if this liquid is too much, it's going to squeeze the heart and is going to produce something called a cardiac tamponade. The pericarditis is inflammation of the double membrane of the pericardium. At the beginning, this inflammation, what is going to produce is one, pain, can produce fever. And third, the inflamed membranes that are sliding one over the other each time the heart contracts and relaxes, systole, diastole, there is going to make a friction that can be heard. The vibration of this friction of the inflamed rough surface of the pericardium can be heard, and it's called pericardial rub. The pericardial rub is in two times, systole and diastole. Is in two times. It's painful, and there is something interesting that can be tested. In Nclex, they make many questions. In which position you place the client? A client with pericarditis feels relief is bending over. If you bend over, if you move your chest forward, like for example, being sitting, leaning forward on a table, as I'm doing in this moment, or being on bed with pillows here and then resting on pillows. Those are the antalgic positions, the position that relieve the pain. And it's tested. You need to know those positions, okay? When you study a patient with, I don't know, a patient with pancreatitis, the position is going to be in fetal position, okay? Because, you know, the fetal position relieves the pain. A patient with pericarditis, okay? You need to know what position to have a patient we have migraine, a patient that is having appendicitis, what position to place a patient that have a respiratory distress, etc. Positioning is very important for the Nclex. So here there is a detail of positioning. The patient need to be placed in the antalgic, anti-pain position, and is the one that I described. It's tested. It's in the Nclex. This is nursing. And this is the acute pericarditis. But then liquid could, not always, could be spilled. And now when the liquid is spilled, there is a layer of liquid around the heart. I don't know if you have been in a swimming pool and you have been playing and you submerge your head and then you don't hear. It's because there is liquid, the sound is not transmitted. When there is a liquid around the heart, the sound is barely transmitted. So this vibration, this locked up that I said produces the heart is not heard very well. And it is said it is called muffle. This word, for people like me that English is not your first language, need to be learned, is called muffle. Okay, muffle heart sound. So it is a manifestation that liquid around the heart. But when the amount of liquid is so much that is squeezing the heart, now I have a complication of a pericarditis with pericardial effusion. This complication is called cardiac tamponade. So you can have pericarditis, having pain, fever, and pericardial rub, and still you are not critical. You can have a pericarditis with muffled heart sound because you have a pericardial effusion, but it's discrete, it's not severe, and you are still not critical. But then you can have a pericarditis with so much liquid that's filled around the heart that is squeezing the heart, so now the heart cannot expand, cannot have diastole. So now the blood that must enter inside the heart, filling the heart before being squeezing the heart and pump forward the blood that is systole cannot enter the heart. So now you have what? An obstruction. So blood cannot enter in the heart. If blood cannot enter in the heart, the blood starts pooling, building up in the veins, waiting for the moment to enter into the heart. So what you are going to notice, the veins, all the veins are going to be very distant, but the most visible are the veins of the neck. But if the blood is not entering the heart, the blood is not leaving the heart. So what do you expect with the blood pressure in this client that has no blood pumped? What is going to happen? The pressure of the blood in the aorta, in the humeral artery, is going to drop. That's why you have the triad. Triad means three strings. You are going to have muffled heart sound because the liquid surrounding the heart. You are going to have neck vein distension, and you have shock hypotension. It's a patient that is critically ill and can die because an obstructive shock. And it is what is called cardiac tamponade. So it is the complication, the unexpected finding in a pericarditis, the cardiac tamponade. It is called the Beck triad, muffled heart sound, 1, neck vein distension, 2, it decreased blood pressure, hypotension, reaching the level of shock, 3. This is a trial, 1, 2, 3, that diagnose the cardiac tamponade. The extreme complication of the pericarditis, which is a sequence that can start with just pain and fever and pericardial rub without liquid, moving to a discrete, mild to moderate pericardial effusion, where the muffled heart sounds are detected, to the level of a squeezing constriction tamponade, in which there is so much liquid that the heart cannot distend, cannot have diastole, and then there is an obstructive shock. What do you expect to find in the lungs of a client with cardiac tamponade, in which the blood is not entering, the blood is not entering, the blood is not entering the heart? How is going to be the circulation of the lungs? With a lot of blood or dry? Dry. So do you expect crackles in a client that has cardiac tamponade? No. You don't expect crackles because there is no blood in the lungs. There is the problem. There is an obstruction. There is no blood in the lungs. Make sense? So that's why it's important, this detail, that you don't expect crackles clear lungs. Makes sense? So what is the life-saving intervention? Pericardiocentesis. What is that? Is introduction of the needle, catheter, etc. in the pericardium to extract the fluid. So what is the role of the nurse? Have first recognize a client with pericarditis having this complication, understanding there is an emergency, and activating the doctors, rapid responding, whatever is activated, to come quickly to do what? A pericardiocentesis that needs to be done by the provider, by the doctor. But what is your role? Having ready the equipment of pericardiocentesis. So your role is diagnosing the condition, calling the doctor, and having ready the pericardiocentesis kit. Oh, when we're talking about shock in this condition, what is shock? Shock, very simple, guys. Shock is a blood pressure that is so low, so low, so low that the blood is not moving inside the arteries. This is shock. And why the blood must move? Because blood needs to transport oxygen that is in the lung to all the tissues of all the body. And this movement requires basically two stuff: a heart that is pumping this, is moving this blood, and a volume, an adequate volume of blood. So those are the basic conditions to have the movement of this blood. This movement can be affected, can be impaired, either if the pump is damaged or when the volume of blood is insufficient, is too low, or when there is an obstruction, like in the case that I just explained, or when there is a phenomenon difficult to understand in which the arteries open, dilate so much, so much, so much that the pressure of the normal volume of blood inside drops because the arteries are too wide. The most common, the consequence of either one of these etiologies is that the pressure is so low, so low, so low that the blood is not moving. You need to have a gradient of pressure to have the blood moving. You need to have the pressure high here, the root of the aorta, and lower here in the capillary. This gradient of pressure is moving the blood in this direction. If for any reason this pressure here drops so much, the blood is not moving, become still, become stagnant. The consequence that the oxygen, which is the reason for the movement of the blood, is not transported to this cell here that needs the oxygen to produce ATP. This cell that is lacking oxygen because the blood is not arriving is going to try to survive, shifting, deviating its metabolism from aerobic in presence of oxygen to anaerobic in absence of oxygen. The anaerobic metabolism, which is the attempt of survival of the cell, is producing a lousy amount of ATP, but is sadly producing a venom, a toxin, a poison called lactic acid. Nclex question: what happens in anaerobic metabolism in shock or any failure of circulation in a tissue, and the tissue is hypoxic? What happens? There is anaerobic metabolism with production of lactic acid. So is lactic acid level in blood an important blood test or parameter to diagnose shock? Yes, and is a standard, is a test that is a standard in the early detection of shock. Makes sense, no? When the blood pressure is low, brain becomes upset because brain needs pressure of blood to have irrigation. And brain activates the sympathetic nervous system. For that reason, you have an important release of epinephrine. So you are going to expect tachycardia, and you are going to expect a tendency to vasoconstriction. That's why this vasoconstriction is more evident in the skin. The skin is going to be pale because the blood is squeezed from the skin by the vasoconstriction, and it's going to be cold and wet. This is the classical pale, clammy skin, cold and clammy skin. No? Okay, and also the body is going to activate hormones that are activated when the blood pressure is low, that are the antidiuretic hormone and the aldosterone. And those hormones are telling the kidney, hey, don't don't waste water in the toilet. Don't pee. Don't produce urine. Because here we have short of liquid, short of blood pressure. So now you interpret that generally in shock, with some exceptions, is beneficial to give liquid. So getting a vein, an important nursing intervention that could be initiated by the nurse without waiting for the doctor's order, is to get veins catheterized, more than one, and preferably with a thick catheter, at least 18. That is the diameter that allows a rapid infusion of electrolyte, ¿cómo se llama electrolyte? No, normal saline, okay, with a saline solution. Crystalloid solution was the word that I wanted to say, and administration of blood. And sometimes with administration of liquid is not enough, and now vasopressors, medication that is more vasoconstriction, like the dopamine, like epinephrine, norepinephrine, etc., could be used for the management of shock. If the blood pressure is low, it's convenient that you place the client in what is called modified Trendelenburg position. The modified Trendelenburg position is simply flat on bed with elevation of the legs. Because when you elevate the legs of a person, okay, you elevate the legs, you are transfusing the blood that is pooling normally in the lower extremities to the circulation. It's like a transfusion. When you place the client in flat position and elevate the legs, it's like if you were doing a transfusion of blood in this client. So this is the position. Oxygen is going to benefit, so you can initiate independently oxygen to this patient while the doctors arrive to confirm the stuff. And of course, it's an emergency that requires the participation of the providers. Make sense? So what you expect in a patient with shock, you expect tachycardia, you expect hypotension, you expect paleness, you expect cold skin, clammy skin, you expect decreased urinary output, less than 30 milliliters per hour. At the beginning, the urine is concentrated, but if the shock lasts too long, the kidneys are damaging, and now the concentration of the urine is lost. You have the most common form of shock is the hypovolemia. It's easy to understand that if you don't have enough volume of blood and liquid inside the vein and the arteries, the blood pressure will drop. It's the most common. And the most dramatic is the hemorrhage, but also dehydration, like in burns clients, in clients who have diarrhea and vomit, in patients who have polyuria, like diabetic, could be also manifested with hypovolemic shock. But the most dramatic is a person that is bleeding. And of course, the solution is to stop the bleeding and replace the lost volume. The other shock that is easy to understand is called cardiogenic, because you understand that you need the pump, you need the pump to move the blood. What happens is you have a massive myocardial infarction that severely damages the pump, the left heart pump, and the blood is not moving. you have, in this case, okay, a cardiogenic shock. The cardiogenic shock need to be treated very aggressively by the doctors. The most important is correcting the myocardial infarction. The best way of reverting or correcting a myocardial infarction is that entering inside the obstructed artery that is producing the infarction and opening this artery. There are different ways of doing that. It's called reperfusion therapy. And of course, the clients are going to receive medication to improve the work of the heart and very advanced, okay, forms of treatment. The obstructive shock, I'm jumping the distributive because it's the most difficult to understand. The obstructive shock, I just explained the cardiac tamponade. I explained the cardiac tamponade. It's an obstruction. If the blood cannot flow, then the blood pressure could drop because the blood cannot flow through the heart. But also, if you have a pulmonary embolism, a massive pulmonary embolism, or you have a tension pneumothorax, something similar occurs obstruction of the blood flow in the mediastinum, in the center of the chest. Depending on each one, the treatment will be different. Pericardiocentesis, thrombolysis, chest tube, etc. And then the distributive shock. What is the distributive shock? It's a shock in which the arteries become so open, so dilated, so extremely exaggeratedly dilated, that even having a normal amount of blood inside, this amount of blood, this normal bulimia, is not enough as to fill the very open arteries, the very open pipes, and the pressure inside drops. It happens when there is a massive release of histamine in anaphylaxis. The histamine is a potent vasodilator. So when somebody that is allergic to penicillin receives penicillin as in anaphylaxis, they have an anaphylactic shock. A person that has, for example, a sepsis, an infection with gram-negative bacteria release something called endotoxin that can produce this vasodilation. So septic shock is another example of vasodilation. And the other is the spinal shock that occurs when the spinal cord injury. Obviously, the medication of choice to revert a distributive shock is a vasoconstrictor. That's why vasoconstrictors, especially epinephrine and norepinephrine, are the medication of choice, but also administration of more liquid to increase even more the bulimia are going to help. So this is the basic concept that you need to have about shock if you have that. What about a coronary artery disease? The coronary artery disease, what you need to know is how to prevent this disease. You need to know about the modifiable risk factor like high cholesterol. The cholesterol is needed in the body, but the problem that cholesterol cannot circulate in the blood independently. Need to be circulating associated with a protein, and this is called lipoprotein. But there are two main types of lipoproteins to learn. The heavy, high density lipoprotein asociada al colesterol, associated to cholesterol, and the low density lipoprotein associated with cholesterol. This is good, this is bad. This is good, this is bad. It's the same cholesterol, but this protein pushes, introduces the cholesterol inside the arteries. This protein, by the contrary, remove the cholesterol from inside the arteries. So the HDL is good, the LDL is bad. What can do a nurse for the cholesterol of a client? First, teach them to avoid the fats that are saturated because they produce more cholesterol, bad cholesterol. And the fats that are saturated are generally from animal origin. And also you need to know that exercising, um, consuming fiber, etc., decrease the cholesterol. We know there are medications that decrease the cholesterol. It's a collaborative, and the statins are the most important. Cigarette smoke need to be stopped totally. Don't decrease the consumption of cigarettes. Stop the consumption of cigarettes. Hypertension should be controlled. Patients with impaired glucose tolerance should be controlled, mainly losing weight. Obesity is a parallel. And physical inactivity with aerobic activity. And of course, the stress is not only. You need to know what is metabolic syndrome. Metabolic syndrome is related with obesity. Not any obesity, mainly is truncal obesity, central obesity. The central obesity is fat accumulated in the artery and increases the waist circumference. This is the parameter that defines the metabolic syndrome. Metabolic syndrome summarizes or conjugates in one condition all the most important risk factors to develop plaque of cholesterol inside the arteries, producing myocardial infarction and stroke. The metabolic syndrome, the type of obesity or metabolic syndrome has been compared with an apple-shaped, you know, apple-shaped figure. Okay. Is a person that has fat accumulated centrally while the extremities are thin. Okay, apple-shaped, okay, obesity. They have glucose intolerance, so have a metabolic problem, glucose intolerance with resistance to the insulin, so they will develop type 2 diabetes when they grow older. They have high bad cholesterol, high triglyceride, have tendency to high blood pressure. And as I said, it's the waist circumference what defines the metabolic syndrome. It's tested that there is a skin integumentary condition associated with metabolic syndrome, these people with type of obesity, that is the acanthosis nigricans, which is this thickening of the skin in the neck, in the armpits, and between the legs, that has this velvety, thick aspect with grooves. You don't see the grooves, the lines there. This is acanthosis nigricans. Patients that develop accelerated atherosclerosis can suffer of angina and myocardial infarction. Angina and myocardial infarction. So when the arteries, the coronary arteries grow this plaque of cholesterol inside, when the obstruction is partial, when the person is doing exercise, will have chest pain. It is a stable angina. When the plaque starts growing and become critically obstructed, the angina can become unstable. So even without exercise, the patient can start having chest pain. So it's less priority the patient that has chest pain with exercise than the patient that has chest pain without exercising. This is worse and is a priority. There is a very rare form of angina in which there is no cholesterol plaque in the arteries. The arteries are clean, but it occurs because the arteries can produce vasospasm. So can occur, okay, a vasospasm in certain situations, especially in the early morning or under a stress situation, and the patient can present chest pain. And when they have a catheterism, the arteries are normal. Those are called vasospasmic or variant angina, also called Prinzmetal angina. Very rare, it's not common. Patients that have chest pain and doctors suspect angina are going to have something called a stress test. This stress test can be simple, just doing exercise, while a simple EKG is done to see the alteration that can occur during the ischemia in the heart, the transient ischemia that occurs in angina, or can have and test using radioactive substances like the MUGA scan. MUGA scan is an stress test that instead of doing an EKG, they inject a radioactive isotope and they make an image of the heart during the exercise. You need to know that the cardiac enzyme, specifically the troponin, Don't elevate in angina, because in angina there is not necrosis. It's just a reversible ischemia of the myocardium. Usually doctors treat the angina with nitrates, beta blocker, calcium channel blockers, platelet inhibitors, and statins. If the plaque grows and breaks, a clot can form over the clot acutely. So now the obstruction is total, and the person will have a myocardial infarction. Now the chest pain will appear at rest. So the pain related myocardial infarction appears at rest, to differentiate that from the pain of the angina that appears during exercise. Nevertheless, there are some patients that can have a myocardial infarction without pain. Women, diabetic clients, yeah, and very old people could have a myocardial infarction without pain. When there is myocardial infarction, the troponin, the cardiac markers elevate, and this is what defines that the patient had a myocardial infarction. The myocardial infarction has two presentations. One presentation is when the ST segment, this horizontal line that is here is called the ST segment, elevates. It's called ST elevation myocardial infarction. This is the typical myocardial infarction. If this infarction is left to the natural evolution, after 3-4 days, this elevation returns back, start returning back to normal, but the Q wave start growing. The normal Q wave should be very small, very discrete, and never measuring more than one little, a square. These big squares have 10 little squares, okay? 10 little squares, okay? So the little squares is 0.4 segments, okay? And the Q wave doesn't last more than 0.4. As you notice, a patient that have an old myocardial infarction has a huge Q wave as expression of the scar of the myocardial infarction, but the initial elevation of the ST segment returns to the baseline. In this myocardial infarction, of course, the troponin elevates, but the troponin should not be elevated more than 7 days. Okay, 7 days is the average of time that the troponin elevates, then returns back to normal to the myocardial infarction. When a patient arrives with myocardial infarction, the most important intervention is trying to open this artery. So the procedure that doctors do to open the arteries are called reperfusion therapy. Um, Meanwhile, doctor plan the reperfusion therapy, we are going to have some nursing intervention. So first, a patient with myocardial infarction immediately should be placed at rest. You don't want the heart to overwhelm. Then you have the diagnostic test. The basic diagnostic tests are the EKG, electrocardiogram, and the troponin. What you need to know about the EKG and the troponin. The EKG can detect the myocardial infarction immediately it starts. There are two possibilities. You know that the ST segment, okay, can go, the ST segment is this horizontal segment, no? That is before the T wave, can go up, and then you have an ST elevation, myocardial infarction, or by the contrary, can go down, and then you have a non-ST elevation myocardial infarction. Both are myocardial infarction. The difference is important for the reperfusion therapy, but it is beyond nursing decisions. So you only need to know that there is two possibilities of electrocardiographing the expression of the myocardial infarction. But what confirms without doubt that the patient is having myocardial infarction is the elevation of the troponin. But troponin doesn't elevate immediately. The pain starts. Takes 2 to 6 hours, is variable, to significantly elevate. So can elevate 3, 4, 5 times, okay, 10 times the normal value, but takes some hours in elevating. So if they ask you which test should be done echocardiogram and troponin, it was one question that when somebody had, to choose EKG, because the EKG allows the diagnosis of myocardial infarction earlier and allows to tell apart the presentation, the form of the myocardial infarction, and can detect, okay, certain abnormalities like dysrhythmias, etc. Independently, that the moment in which you do the EKG, you need to know that the patient needs to be monitored, because the way in which a person with myocardial infarction usually dies of the myocardial infarction is having a ventricular dysrhythmia. And having a monitor connected is are seconds of time that are gained in helping this client if the client develop ventricular dysrhythmia, because the monitor immediately is going to turn on an alarm that when this dysrhythmia appears. The patient that have the myocardial infarction, meanwhile the reperfusion therapy is established, can receive some medication that are called first aid medication, that are the nitroglycerin, the aspirin, the oxygen, and the morphine. There is a famous mnemonic model, okay, for that, but this is not necessarily the order. When a person is having a myocardial infarction, the first medication to be administered is the nitroglycerin. The nitroglycerin, is administered at 5 minutes intervals, 5 minutes intervals, and in this interval, a second medication should be administered with priority. Medication that has demonstrated decrease of mortality in myocardial infarction, which is aspirin. This aspirin is not important. The dose should be chew and swallow, okay, to accelerate the absorption. If the patient presents decreased O2 saturation, o sea, the O2 saturation is less than 95%, oxygen should be added. So it means that not always oxygen is added. It's if the O2 saturation is decreased. And the morphine is given if the pain doesn't disappear with the night, which is common. It's the most common situation. So now, when is given the morphine? When the pain doesn't disappear with the adequate doses of nitroglycerin. Patients, I say, should be placed at rest, should be monitored, and should be avoided any effort, like, for example, straining, like why stool softeners are frequently given, and patients should not walk to the bathroom. But to prevent too much straining, they are usually, they're stable, allowed to sit in a bedside commode to do number two, okay, to do number two. Uh, One of the therapies, the reperfusion therapies, in which you can be involved is the administration of fibrinolytic therapy. Fibrinolytic therapy are medication of the family of the TPA. TPA here is tissue plasmic activator, recombinant tissue plasmic activator. The most frequently used in America is the alteplase. 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 Alte. Sorry. They always ends in A's because there are enzymes. Are thrombolytic medication, thrombolytic enzymes that are able to dissolve the clot that is obstructing the coronary artery. Of course, the doctor will order you to initiate the IV infusion of the alteplase, and this is a reperfusion therapy. So you need to wait for the doctor's order. Not all the clients are going to receive alteplase. Alteplase has several conditions. Uh, there are doctor's conditions that are not pertinent to us, like, for example, only patients with ST elevation MI receive alteplase. The non-ST elevation MI don't receive alteplase, but this is doctor business. Second, if there is a possibility of a more invasive reperfusion therapy, like cardiac catheterization with stenting, is preferred to the alteplase, but it is not nursing business. What is nursing business is that if the doctor decides to administer alteplase, there is a window period in which the alteplase is beneficial, and beyond which this window, the the alteplase is not beneficial anymore. This window period is approved by the Food and Drug Administration for 6 hours. But this window period has been prolonged in recent research by other specialties. So the decision of how many hours is not nursing business. Is not going to be the question. What is the question is that it's important to know in nursing, in the assessment, at what time the pain started, because the doctor will count how long it happened, when the MI started, and is going to decide if the benefit of the alteplase is still present and for the administration that took place. So an important detail that a nurse needs to report to the doctor is exactly as possible at what time the pain started. And you need to know that the alteplase, the main side effect is risk for hemorrhages. And of course, there are contraindications to give alteplase. That is a patient at risk for bleeding in the brain, like having an aneurysm, having a brain hemorrhage, etc., bleeding in the stomach, etc. The other, more invasive procedure doctors can do to the perfusion is the catheterism with angioplasty and placing of stents or the open heart surgery to do coronary artery bypass and graft. The Here you have, for example, how doctors can enter inside the plaque, enters a balloon, it's called angioplasty, and deploy an stent to leave that in circulation. Or they can take a vein from the legs to do bypasses in the heart. It requires open heart surgery, so you are going to have a client with 2 wounds, one in the chest with drainage and a wound in the legs to be cared. So look at this question. Patient with myocardial infarction, the pain is rated 8 out of 10 that was not alleviated with 3 doses of nitroglycerin. Which of the following the nurse expect to be given by protocol? So obviously, you have giving aspirin, which is not the indication, giving oxygen, which is going to depend on the saturation, giving more nitroglycerin. The nitroglycerin, the main side effect is hypotension. Nitroglycerin is a potent vasodilator. So nitroglycerin should be given. Meanwhile, the systolic is above 90, the diastolic is above 60. And nitroglycerin, when doesn't demonstrate benefit, then, as you said, morphine should be given. Morphine has a double function in the myocardial infarction. It's a vasodilator. For your information, morphine is a potent vasodilator. So vasodilating, the morphine decreases both preload and afterload. If the heart has less load, less preload, and less afterload, then needs to work less. If the heart doesn't need to work so hard, so it needs to work less, requires less oxygen. And precisely myocardial infarction is localized lack of oxygen in one part of the heart. So is this going to benefit the myocardial infarction? The other benefit is going to sedate the client, so decreases the activation of sympathetic nervous system, and is going to improve the pain. So that's why the reason of giving the morphine. Which finding is not expected in the normal evolution of an uncomplicated myocardial infarction? Notice that the question is tricky, the wording is tricky. It's like it's not a double negative, but it sounds like a double negative. If the myocardial infarction is not complicated, what is not expected? What I did I translate to Spanish this question? No. Keeping the language, I reworded the question. So I had problems understanding this wording. What I did, I reworded the question. I say, if the myocardial infarction is not complicated, why I should not expect to see? Now I understand what I'm looking for. I'm looking for something not expected in a normal evolution, a non-complicated myocardial infarction. So let's see what is not expected. So A, ST elevation. ST elevation is expected. Returns to baseline. Returning to baseline is expected. I told you by the second day. I say that usually it can last 3 days, okay, to return. So this is returning a second day is a good evolution. So it is expected. This is not the answer. So I rule out those. A 0.04 seconds Q wave is observed in some precordial leads. It is a normal Q wave. It is a normal Q wave. So it is no problem. It is something that is not, is not rare. Troponin returns to normal after 11 days. I have a problem here. I said that usually troponin returns back to normal around 1 week, around 7 days. So I'm concerned about this option. So I place my interrogation here. Let me see the last. Client heart rate increases to 98. 98 is a normal heart rate during a stress test after myocardial infarction. Yes, after the myocardial infarction, when the patient is already recovered, doctors do a mini stress test to see how the person performed during exercise, how the heart was left after the myocardial infarction, and all the intervention they did. And having this heart rate is okay. So obviously it is not. So need to be seen. Okay, what do you think is happening when a person has a myocardial infarction? Day one have a myocardial infarction. Yeah, the troponin elevate and should return back in 7 days. Now the troponin stays elevated 11 days. What do you think happened?
I think no repercussion will.
Okay, a normal myocardial infarction left without treatment. If the patient doesn't die, should have the troponin returning to normal in 7 days. Now the troponin stay elevated 11 days. What could explain this? Reinfarction. You can have a patient that have an infarction, and now you can have a reinfarction or extension of the infarction. So in the first day has the first infarction, no? And troponin elevate. But now in the 5th day has another infarction, and now that's why the troponin stays elevated. So this is a manifestation of extension, re-extension of the infarction or reinfarction. This is what happens when the troponin stays elevated longer than expected. What client should the RN see first? MI 24 hours with elevation of ST segment. MI 4 days, muffled heart sound. MI 72 hours, sporadic supraventricular premature contraction. MI 12 hours, elevation of troponin 4 times the normal. So what we discard? We discard A, it is expected. ST elevation, 1 day after infarction is expected. I discard D. So elevation of the troponin, 12 hours myocardial infarction is expected. Yeah. So now I'm left with this. Premature contraction. Okay. The bad are ventricular, not supraventricular. The bad, but the really bad in myocardial infarction are the PVCs, premature ventricular contraction. If the contraction is supraventricular, okay, has less risk than the premature. So having a sporadic supraventricular premature contraction has low risk. What means that the patient is having muffled heart sound, that this myocardial infarction is complicated with a pericardial effusion. So this is the concern. This is the client should be seen first. Yes, one complication of myocardial infarction is that the infarction can extend to the pericardium, and this extension to the pericardium can produce pericardial effusion and muffled heart sound. Client with history of coronary artery disease arrived to ER with chest pain. the nurse is going to administer nitroglycerin as per protocol, which medication previously taken by the client contraindicates giving the nitroglycerin. Which one is the medication that contraindicates nitroglycerin?
Tadalafil.
Tadalafil. Tadalafil is an erectile dysfunction medication like sildenafil and tadalafil that are medications that combined with nitroglycerin produce a severe catastrophic refractory hypotension that could be mortal. So it is a classical question. And because time runs out, you need to understand that the main consequence, the main cause of death in myocardial infarction is cardiac arrest during the myocardial infarction because ventricular distress. And it is something that we